Hello, this is Andrea Stafford, and this is a presentation for Principles of Epidemiology for the University of Kansas Medical Center, Depression Leading to Opioid Use and Misuse. The significance of the exposure being depression, is that chronic pain and depression are highly comorbid conditions. Having chronic pain increases the risk of depression, and the presence of depression is a predictor of developing chronic pain in the future. Depressed patients are nearly twice as likely to continue taking their opioids long term. Opioids may produce transient mood elevation or partial relief of some depression symptoms, but do not produce comprehensive and sustained benefit. Significance of the outcome, which is opioid abuse, is opioid abuse and dependence is a serious chronic disease that portends diminished quality of life, significant mortality, increased societal costs such as lost worker productivity, and increased strain on the criminal justice system. Prescription opioids are the fastest growing form of drug abuse and the most common cause of unintentional overdose. There are 9 million Americans that report using opioids for medical reasons, and hydrocodone is the most prescribed of these drugs, with over 130 million prescriptions per year. Inappropriate use of prescription medication has often been associated with medical and psychiatric complaints and symptoms. Study number 1, depression and prescription opioid misuse among chronic opioid therapy recipients with no history of substance abuse. This study is a cross-sectional telephone interview study from Group Health Cooperative and Kaiser Permanente of Northern California. The sample size is 1,334 patients, ages 21 to 80, and of these patients that had filled at least 10 opioid prescriptions or received at least a 120-day supply in the year prior to the interview. These patients were receiving chronic opioid therapy. The outcome measurement was they asked about 3 forms of opioid misuse. 1, self-medicating for symptoms other than pain. 2, self-increasing doses. 3, giving to or getting opioids from others. The exposure was measured by a PHQ, which is a patient health questionnaire, which consists of 8 items. The limitations of this study were they used a broad definition of opioid misuse, and the response rate was not as optimal as the researchers would like, since many people on chronic opioid therapy are disabled. The strength of comparison to previous studies was found that if depressed patients were not in full remission, they remained at increased risk of opioid misuse and overdose. Patients on chronic opioid therapy are at high risk for overdose, this being either accidental or intentional. The demographic covariates of this study were a stratified sampling, selecting equal numbers of patients within 3 dosage strata, being 1 to 49 milligrams, 50 to 99, and 100 milligrams or more. Study number 2. Symptoms of depression are associated with opioid use regardless of pain severity and physical functioning among treatment-seeking patients with chronic pain. These study dates were from November 2010 to February of 2014, consisting of 2,104 new patients with chronic non-cancer pain. This was also a cross-sectional study, and the population were all new patients were mailed a packet of questionnaires before their initial visit. They only used the patients that completed all the data on the opioid use, pain, functioning, depression, and all covariates that were included in the analysis. The outcome was measured by self-report, yes equaling a current opioid user and no being a non-opioid user. Exposure measurement was measured by 2 multivariate logistic regression models, and this examined individual and combined relationships of depression and pain. The limitations of this study were that the study design limits the ability to make any causal inferences regarding the effects of opioid use on pain and depression. The results of this study were also non-generalizable. The strength of comparison is that this is a large study exploring depression as a moderator of the relationship among pain severity and physical functioning and opioid use. The demographic covariates of this study were age, sex, education level, race, ethnicity, pain variables, and affective symptoms such as depression and anxiety. Study number 3. Non-medical use, abuse, and dependence on prescription opioids among U.S. adults. Psychiatric, medical, and substance use correlates. This study dates were an analysis between 2002 to 2004 on the National Survey on Drug Use and Health. This sample size was 91,823 patients that were 18 years or older. This was also a cross-sectional survey consisting of civilian people who were non-institutionalized. They collected information on the prevalence of substance use and psychiatric comorbidity. This was a 50-state design study, independent and multi-stage area probability sample for each state. The outcomes and the exposures were measured by this National Survey on Drug Use and Health. This is a computer-assisted personal interviewing as well as audio computer-assisted self-interviewing. The respondents that completed this survey each received $30, and these questions concerned past and current illicit drug use. The limitations in this study were the inability, again, to define causal relationship. There was recall bias and questionable analysis using the DSM-4 criteria. The demographic covariates of this study were age, gender, education level, race, ethnicity, marital status, income, population density of residents, employment status, work absenteeism, insurance status, Medicaid coverage, and arrest booking for crimes in the past year. The association between depression and opioid misuse are broken down with each study. Study number 1 compared with patients who are not depressed. Patients with moderate and severe depression were 1.8 and 2.4 times more likely, respectively, to misuse their opioid medications for non-pain symptoms. The prevalence of depression was found to be between 0 and 4, which is not depressed, 36.9%. For mild depression, 40.2%. For moderate depression, 47.2%, and for severe depression, 51.8%. For study number 2, it was found that 55.89% reported current opioid use and showed a worse phenotypic profile compared with non-opioid users. Symptoms of depression were found between 43.6% versus a 26.8%. Among these patients with symptoms of depression, the probability of taking opioids did not change based on their pain severity. Current opioid users reported more symptoms of depression and anxiety, and depression emerged as a moderator of the relationship among opioid use, pain severity, and physical functioning. For study 3, there was a direct relationship between number of psychiatric symptoms and strength of association with abuse dependence on prescription opioids on an unadjusted analysis. Heineken's criteria. The chance found for study 1, 2, and 3 each use a 95% confidence interval. For study 1, 1.46 to 4.02 with a p-value of 0.01. Study 2, 1.51 to 2.33 with a p-value of 0.001. And for 3, 2.8 to 3.6 and a p-value of less than 0.001. The bias in each study all had sample selection and recall bias. Confounding variables are listed, and the strength of association for study 1 was a strong association with an odds ratio of 2.42, and study 2 a moderate association with an odds ratio of 1.87, and in study 3 a strong association with an odds ratio of 3.2. Further, Heineken's criteria shows that there was biological plausibility in each of the 3 studies. There was also consistency found. There was no temporality, as well as no dose response was found in each of the 3 studies. Conclusions and implications for further research regarding depression and opioid misuse. This brings to light a need for further research concerning the natural history of prescription opioid use disorder. The illicit market for prescription opioids is not well described. The best strategies for prevention and treatment of non-medical use of prescription opioids, especially among patients with painful disorders, is unknown. This should alert clinicians to the risk of patients with depressive symptoms using opioids to relieve these symptoms and using more opioids than prescribed. Pain reduction, improved functioning, and quality of life are typically considered broad markers of therapeutic benefit. Yet patients on opioids appear worse off in all three of these categories. This suggests that in clinical practice, opioids are often used by patients with chronic pain and depression to treat a complex combination of physical pain and mental or societal pain. It also appears not to be possible to promote the treatment of physical pain and discourage the treatment of mental pain through opioid treatment guidelines. Here are the references listed. Thank you very much for your time.